You're listening to the Sick and Good podcast. My name is Dustin Messick. I'm a registered dietitian nutritionist and a cancer survivor.
My name is Colin Goodwin. I'm a clinical psychologist and a cancer survivor.
In 2024, we are highlighting the Cancer Awareness Month in a special series.
We're promoting wellness by having discussions on screening, treatment, and recovery throughout the cancer journey.
To find a balance between sick and good.
That during the cancer process, both can be true.
The Sick and Good podcast is for educational purposes only. The podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition or treatment and before undertaking a new healthcare regimen.
Welcome to the Sick and Good podcast Cancer Awareness Series. In 2024, we'll be highlighting monthly cancer awareness topics. I'm pleased to introduce Dr. Hui Amy Chen as our first guest for January's Cervical Cancer Awareness Month. Dr. Chen is a gynecologic oncologist who offers comprehensive care to women with cancer of the genital tract. She's actively involved in recruiting and developing clinical trials at UC Davis Comprehensive Cancer Center. And she also has a special clinical and research interest in integrative oncology and complementary and alternative medicine. Wanted to welcome you, Amy, and thank you for being here.
Thank you so much for having me. It's really an honor.
I'm interested in hearing about your career path as a gynecological oncologist and your current practice. Could you just tell us about that role?
Yeah, so I kind of serendipitously fell into the role of being a gynecologist. I didn't know that's what I wanted to do when I started my journey into medicine, but I did know that I wanted to work with women and advocate for women's health. And so even when I began medical school, OBGYN was always a specialty of interest for me. I think with OBGYN, we're able to take care of women with all stages of their lives. And so when I started my residency in OBGYN, that's when I had my first experience in GYN oncology. And it was really through the interactions with the patients and their family members and their journey through cancer that really touched me. And I found that even after I was done with those rotations, I would go back and visit the patients and see what happened with them. And I had some great mentors along the way too, some very inspiring and supportive mentors. And I wanted to continue working in this field. In our field, we are able to really take care of women from the beginning of their cancer diagnosis all the way to the end of life. We do very complicated surgeries and robotic, minimally invasive surgeries, large surgeries to remove a big amount of cancer. And we also give chemotherapy and targeted agents. And so short of radiation, we're able to take care of all facets of their cancer. And I think that is a very unique aspect of gynecology. And so, as a gynecologist, I take care of ovarian, uterine, cervical, vaginal, and vulvar cancers, and really able to have a good connection with my patients and their families as well along the way. And that's really what drove me to do it and why I am continuing to be inspired to do this field, every day.
You definitely sound very passionate about your work. In honor of the Cervical Cancer Month, can you tell us what cervical cancer is and how to prevent it?
Yeah, so the cervix is actually a part of the uterus. It is the most external part of the uterus. And the cervical cancer is the third most common gynecologic cancer in the United States. And one of the very neat things from my gynecologic oncology standpoint is that cervical cancer has ways that we can prevent it and also treat it especially very early. And so it is one of the most preventable and treatable forms of gynecologic cancers that I get to see. One of the reasons why that is the case is that over 95% of cervical cancers are related to something called HPV or human papillomavirus. And we do have screening as well as a vaccine to help prevent HPV as well as screen for precancerous changes before it becomes cancer. So I think it's a very unique, unique type of cancer, but very unique type of gynecologic cancers, whereas I don't have that available to me for the other types of cancers I treat.
So would you say that the HPV vaccination is basically essential?
I would say it is very essential. HPV vaccines can prevent over 90% of cervical cancer. And if I had a vaccine that can prevent all of the cancers I get to treat, that would be really awesome.
That would be awesome.
Right? But we have one for this cancer. And so I think that if all people eligible for getting the HPV vaccine really should. And the HPV vaccine is approved for ages 9 to 45. The target age is for ages 11 to 12 in the United States. The World Health Organization would recommend it between the ages of 9 to 14. And that's for both boys and girls that, are all eligible for getting the HPV vaccine. And so I would strongly encourage everybody to think about getting it. And even if you haven't gotten it before, it is strongly recommended.
So if somebody is already diagnosed, is it too late to get this vaccine?
So I think if you ask experts, it's a little bit of a mixed opinion. My general opinion is that it's not too late to get the vaccine, but you do have to consider some of the other factors involved in it. So there are many different strains of HPV. And, the most common strains that are associated with cervical cancer are HPV 16 and 18. But the HPV vaccine, the one that's available in the United States, is called the Gardasil 9-valent, and it covers 9 total strains of HPV, 2 of which are more associated with genital warts, and the other 7 are associated with over 90% of cervical cancers and other cancers of the lower genital tract. And so I would say that even if somebody had previously been exposed to one of the strains of HPV and has caused either precancerous or even cancerous changes, getting the HPV vaccination could still protect them from the other strains of HPV that they may have not been exposed to in the past. The implications to consider is the cost and the insurance coverage. So although technically the vaccine is covered until age 45, not all insurance companies would cover that. And so sometimes this vaccination might have to be paid for out of pocket. And so, in terms of the financial toxicity related to that, I think it is a discussion that somebody should have with your provider, whether or not insurance coverage is a component of that decision making and whether or not that somebody has the means to afford it. But I do think that if it's available and affordable, that everyone should get the HPV vaccine if they can.
That's definitely really interesting. Have you had any cases where
transmitted virus? I would say the great majority of us have been exposed to HPV sometime in our lives. And so most of the time when we are exposed to HPV, our bodies will naturally clear it. Our immune system will help get rid of it just like any other virus. I think the challenge is when sometimes our immune system doesn't completely get rid of the HPV. HPV can linger in certain cells and over time can cause changes in the cells that can lead to precancer, and then without treatment or follow-up can eventually lead to cancer.
Can you tell us about what's changed as far as the prevention for cervical cancer? One thing I was maybe curious about is that if there's particular guidelines for Pap test or Pap smear with the HPV vaccination as well.
For sure. So I think the key hallmark in terms of true prevention is the HPV vaccine, because being vaccinated really prevents the HPV from taking up into the cells and eventually causing these precancerous and cancerous changes. And so what did Ben Franklin say? An ounce of prevention is a pound of cure. So I think that's the best way for decreasing the risk of cervical cancer. But in terms of screening, we have had some changes for what we do for screening. And so it is recommended that all women at ages of 21 begin their cervical cancer screening. And I just wanted to make a side note that, I'm going to be using terms like female and women during this discussion just for the simplicity of it. But I understand that not all people who are at risk for cervical cancer necessarily identify as being female. And I understand that gender can be non-binary as well. So I do want to make a side note that I recognize that, but I think for the simplicity of this discussion, I am going to be using some of these terms. And so it is recommended that all women at the ages of 21 begin their cervical cancer screening. In terms of cervical cancer screening, it's oftentimes a combination of what we call the Pap test, which has changed from the previous, what we call a Pap smear. And the reason is what a Pap smear used to be is that we take a swab of the cervical cell, smear it onto a microscope slide and actively look at it under a microscope. Now what we have is better technology that once we take the cells and we put it in a liquid solution, then send it to the pathologists are able to isolate those cells much better and with more accuracy determine if there's any atypical cells. So that's what we consider the Pap test. And then there's the HPV component of it. And we're really looking at HPV, sometimes DNA or sometimes RNA to detect for the presence of that virus. And so cervical cancer screening is a combination of both the Pap test and HPV testing. So the CDC recommends that between the ages of 21 to 29, that women are using the Pap test, not necessarily HPV screening upfront every 3 years. And that's a change because previously, I would say, almost 10 years ago, we used to recommend women get cervical cancer screening every year. And what we found is that has led to higher numbers of false positives and additional procedures and invasive procedures
Complications.
I'm sorry?
I said complications.
And complications related to that and pain and,
discomfort.
And psychological distress from having those results, where it didn't really change the outcomes and it didn't really decrease the risk of cancer and cancer outcomes. And so the United States Preventative Task Force, as well as the American Cancer Society, has increased the time period from screening if people have had normal screening in between. After the age of 30 and above, then the primary recommendation is to either have what we call co-testing, which means both the Pap test looking for atypical cells plus the HPV test, or to do HPV primary testing every 5 years. And then another alternative is continuing doing just the Pap test, the looking for the abnormal cells every 3 years. I would say that the HPV primary testing and the what we call co-testing, so both the Pap and the HPV are the preferred regimens, and then the just having the cytology is an alternative, especially in areas where maybe HPV testing is not readily available.
Thank you so much for then kind of highlighting the changes in screening procedures and specifically talking about the preventative measure of HPV vaccination. Also wanted to just thank you for speaking to diversity and acknowledging that in the context of this conversation where we are talking about the female and women being the population.
Right. And I think what I wanted to add was more also related to, the social determinants of health and related to cervical cancer and cervical cancer screening too. I think it's really important to be inclusive, especially for our LGBTQI community, and understanding that there are risks for cancers like cervical cancer, but there may not be undergoing the screening because of potentially maybe not having that conversation or understanding what the risks are for developing these cancers because of, maybe not even recognizing it from the provider standpoint, honestly. And so I think it's really important to keep that in mind.
Are there other social determinants of health that you've seen as far as the treatment of cervical cancer, or even just maybe barriers to then having a message for prevention or screening?
Yeah, I think that we are seeing that a lot with not just cervical cancers, but how disparity really impacts our ability to screen and treat many different cancers. And there have been studies and research showing that, in the United States, somebody's location, rurality, socioeconomic factors, as well as other personal identity factors like race, ethnicity, gender can impact the ability to be able to get adequate screening, and the rates of adequate screening are lower. I find that in a cancer that we have clear things that we can use to prevent as well as screen and treat early, I still see women with advanced cervical cancers. And I think a lot of times there are impacts from their outside factors, external factors that lead them to be diagnosed with late stages of cervical cancer. And I think we need to do better as a society and as a healthcare system to be able to try to address and target some of those disparities. And I'm going to put a side note here. I mean, I think if you look at certain countries like Australia, for example, they've done an amazing job with decreasing the rates of cervical cancer. I think it's estimated that by year 2028 to maybe 2035, that cervical cancer may be eradicated in Australia. And one of the reasons why that is they've put a lot of effort in terms of cervical cancer screening and HPV vaccination. In Australia, it's more of an opt-out policy. And so they're able to target the great majority of youths who are eligible for HPV vaccination. And then it really impacts the society, but also in the individual level for decreasing their risk of cervical cancer and other cancers related to HPV. But even so in Australia, there are concerns for people from, for example, Aboriginal cultures that may be not getting as many resources for screening. And so the disparity still exists in countries like that. And if you look at worldwide, cervical cancer is the fourth common cancer overall for women in, especially low and middle income countries. And so you see the disparity not only on a country to country level, but an international level. And it's something that I think there needs to be more effort globally to try to implement more prevention and screening programs out there, because it is truly, truly a preventable cancer.
How has COVID-19 affected patients with cervical cancer?
I think that's a great question. On a personal anecdotal level, in general, I see more patients now that it's 2023 coming in to seek care with more advanced stages of cancer. And the thing about cervical cancer is even in earlier stages of cancer, it is very treatable and very curable. However, when it's advanced and especially metastatic, it's, unfortunately very hard to be cured, and it's very aggressive in that setting. And what I found is that because of all the impacts from, access to, the fear of the, COVID-19 and the implications of the virus, people may have not been going in for their routine screenings, or when they have symptoms, maybe waiting until the symptoms have gotten to a really bad threshold before coming in to seek care. And so I think that the amount, just anecdotally from my professional experience, amount of people coming in with more advanced cancers, it has increased. I know the data for that will come out probably in a few years, and looking at actually how frequent later stages of cancer are being diagnosed. But what I think there has been already data showing that there's been a significant drop in cancer screening in general during the pandemic. And so we will see the long-term effects of that, years down the line when, people have missed a bunch of screening opportunities. But it's not too late. Now is the time. Even if you missed screening the last 3 years,
Yeah.
you can Go to see your provider now. We will see you. We will get you screened and treated if necessary. But it was a hard time for everybody for years, and definitely cancer treatment and cancer outcomes were impacted by COVID-19 too.
It's also a great reminder of what happens when we don't see the doctor for a while.
And when there's barriers to then having these screenings. And, I'm interested in hearing about perhaps some clinical trials that you've been able to take part of regarding cervical cancer.
Yeah, I think in cancer treatment in general, this is a really exciting time because there are a lot of more novel therapies coming down the pipeline for treating cancers. And specifically in cervical cancer, the impact of immunotherapies are being shown. And so, for example, a recent clinical trial that we at UC Davis participated in was using immunotherapy called pembrolizumab. It's called immune checkpoint inhibitor. And so, what I kind of tell my patients is oftentimes cancers put up a little marker called PD-1 that prevent immune cells from seeing it, almost camouflaging from the immune system. And these therapies, what they do is they block that camouflage marker to allow the immune system to help recognize it as an abnormal cell and hopefully target it. And so we've seen some trials in what we call recurrent cervical cancer showing that this immunotherapy can be helpful. But most recently, we're using it in the upfront setting. So traditionally, locally advanced cervical cancer is treated with a combination of chemotherapy and radiation. And we were participating in a randomized trial for randomizing some of the patients to adding the immunotherapy with their chemotherapy radiation. And just hot off the press, this press release came out, I think 2 weeks ago, that showed that there was a pretty significant improvement in progression-free survival. Now, the full raw data hasn't come out yet, so I can't give you numbers, but the trial sponsors mentioned that they met their progression-free survival outcome, meaning that we will be using this immunotherapy upfront for cervical cancer, especially locally advanced cervical cancer. So although it is potentially curable, there is a very high risk of it coming back. And so potentially adding this agent will really decrease the risk of recurrence for these women.
Wow. That's really encouraging to hear that there's the advancement in treatment here. And as I was listening to you talk about what immunotherapy really does for those markers, I was thinking immunotherapy, the champions of hide and seek, right? In the cancer world, right? They're able to then uncover or really be able to then see those markers so that there is that better opportunity to treat it. And like you said, hopefully then have that reduce the reoccurrence of the cervical cancer.
Right. And I think this is one type of immunotherapy. I know there's lots of research ongoing, not only in our site, but sites around the country and around the world, looking at many different facets of immunotherapy and how can we target the immune system to help identify and treat cancer better.
Yeah, I think that's definitely going to be a much bigger, under a lot more studies just since COVID-19, like looking more directly at the immune system. More recently, I've heard a lot around CAR T. And I think even they're doing some trials with cervical cancer and CAR T. You don't have to speak to this topic, but I just was curious if you have heard anything about CAR T.
Yeah, we've had some what we consider phase 1, what we call all solid tumor type of clinical trials for CAR T therapy. So what CAR T therapy is a chimeric T cell. So T cells are a type of cells in the immune system. Oftentimes are the worker B cells that help find atypical cells like cancer cells and get rid of them. And the thought process is if we are able to modify those T cells to better detect cancer, we can use them more effectively to get rid of cancer. And there has been lots of work done with CAR T cells and certain blood type cancers like leukemias, and more the CAR T cell clinical trials are moving into what we call solid tumors. And so cervical cancer is a type of solid tumor. And there are a number of trials out there. I would recommend going to clinicaltrials.gov if that's something you're interested in to find out more information about centers in the area that might offer some of the CAR T trials. But it is interesting if we're able to either train your body's own immune cells, so something called autologous CAR Ts, where we are able to extract T cells and then using a marker on the cancer cell, train them to recognize that marker, or using CAR T cells that are already pre-made in the laboratory setting to help fight cancer cells better. It is definitely another way of trying to get to the bottom and treat cancers that are sometimes very hard to treat.
Yeah, I think we're in a really exciting time with how popular immune therapy is now, like just as far, because I remember hearing about immune therapy like over 10 years ago, but now it seems like there's more clinical trials than there was back then. I'm also curious if there's any other novel agents that you know of that have been used to treat cervical cancer.
Yeah, so another type it would still fall under the class of immunotherapy, though it works a little bit differently than some of these other immunotherapies we talked about, is something called an antibody drug conjugate. And there's been one recently approved for the use of recurrent cervical cancer. And what an antibody drug conjugate is, it has the ability to recognize certain markers on the cancer cells, and attached to its little tail is what we call a cytotoxic agent, oftentimes similar to chemotherapy, but it causes DNA damage and kills cancer like chemotherapy does. The added benefit of using the antibody drug conjugate is because it attaches to the marker on the cancer cells. The cancer, it almost what I call injects, it's something called endocytosis, but it injects the chemotherapy agent directly into the cell itself. And so it eliminates the need for using transporters and other things that, for the chemo to work. And so for cervical cancer, our recent drug that has been approved is called tisotumab vedotin. And it attaches specifically to tissue factor, and it has been shown to be helpful for treating recurrent cervical cancer. It's a novel agent, and it gives us more tools on the toolkit for treating recurrent cervical cancer, which we're always looking for more of. Is it the cure for cervical cancer? Unfortunately, probably not, or not yet, but it is definitely an extra tool in the toolkit that has been found to be effective, and really good to know that there are more things coming down the pipeline.
I was excited to hear about those novel agents. And then also had the thought, like, those are some $50 words right there. I'm sure that these are going to be on the National Spelling Bee, right? Very hard to pronounce, and I'm sure even harder to spell. But I'm wanting to just thank you for your expertise and sharing your review as a gynecological oncologist. I'm curious if there's maybe any other recommendations or suggestions you have for our listeners, in honor of the January Cervical Cancer Awareness Month.
I think the key take-home points, I hope your listeners are able to get are that cervical cancer is very preventable. Really think about getting HPV vaccination, even if you have been exposed to HPV in the past. I think it would still be beneficial to be vaccinated. The target age is target age 11 to 12. I think sometimes vaccinations do have maybe a socio-political tone regarding them. And really, this is a cancer prevention vaccine. It's to help your child, that individual, prevent cancer in the future. And so we really shouldn't have to consider anything political related to this vaccine. And then getting your cervical cancer screening is imperative. And if it's normal, really every 3 to 5 years is all you need to keep doing. And, if it's abnormal, then it's actually a really good time to intervene and be able to treat it and to prevent it from developing any further. So there are guidelines about when to stop cervical cancer screening. And so in general, women at the age of 65 can stop cervical cancer screening. However, there are lots of caveats related to that. And to be able to stop screening, somebody must have had really routine cervical cancer screening that has been negative for at least 10 years before stopping screening. And recently, we published an article showing that women over the age of 65 were actually found to have more aggressive or later stages of cervical cancer. And one of the things, although our study didn't really look into this into details, one of the things I wonder is that are we stopping screening for women, older women, without them truly meeting the criteria? Suppose someone goes to see their doctor and they're already 67. They may have not gotten pretty routine, adequate screening in the 10 years leading up to that. But they see their provider at 67 and they say, oh, you're over 65. You don't have to have any more cervical cancer screening. Well, that person really should not have had stopped screening and should continue. And it should not just be about the age, but specifically the age and also meeting all the negative criteria to stopping screening. And so I think it's really important for older women to be mindful of cervical cancer just as much as younger women.
And what I'm hearing is making sure that there's a significant amount of time before that cutoff age of a negative test and having that, was it 10 years of data so that they're looking at that likelihood of it being maybe a later stage, or rather later in life, cervical cancer diagnosis.
Right. And I think what I'm trying to say is that, if someone hasn't had adequate screening and then just stops screening, they may have had they might be harboring cervical cancer, precancerous changes at that point in time, but we would never know until it became cancer and became more advanced stage, and that person never got truly screened for it. Does that make sense?
Absolutely. Yeah. They're not necessarily having, we talked about is having those chances to have those screens until the cutoff age.
Correct. Yeah.
But it's interesting to hear that there's still, some risk and there's some maybe gray area as far as whether that is an appropriate thing to, and say that there's a hard line for them just stopping at that age to have those cervical cancer screenings completed.
Right. And I think as long as they meet the criteria, I think the reason why it is appropriately to stop screening is because it does take years for someone without any evidence of HPV infection or precancerous changes to develop into cancer. And so I think part of the United States Preventative Services Task Force is, weighing the risks of continuing screening versus the overall cancer outcomes. Of course, if there's any symptoms or if there's anything in terms of other history that would make you concerned, I don't think you should follow that as a hard line. I think we should evaluate every patient as an individual. But that's the reason why those general recommendations regarding stopping screening at 65 exist. But there are lots of asterisks associated with that age time. And so you do have to make sure all of the criteria are met at age 65 to truly be able to stop screening.
Well, Amy, I wanted to thank you for being part of the series here that we're kicking off in 2024. And thank you so much for sharing your expertise on cervical cancer and gynecological cancers as well.
Thank you so much for having me. And I'm truly honored to be your first guest to kick off the cancer awareness series.
Our podcast will discuss topics related to cancer treatment and the recovery process, including diagnosis, family support, resources, medications, and nutrition. We aspire to have conversations pertinent and relevant to the cancer journey. Thank you for listening to the Sick and Good podcast. We'd like to invite you to connect with us on our social media and Instagram and Facebook accounts. We're also happy to share that we have launched the Sick and Good podcast website, sickandgood.com. This website is a place to read our bios, subscribe to the podcast, listen to full episodes, or read full transcripts, and contact us with your questions or comments. We care about your listener experience and would love to hear from you to keep the conversation going on the topics of cancer and wellness.